All right, week number 5. In this week, we're going to go over the cervical spine. You can see on the guidelines is a blue tab, guidelines to JOSPT link to treatment classifications. So we can go over the different classifications and read through it and discuss neck mobility with neck pain with mobility problems, stability problems, headaches, or radicular pain. We start going into observation, the exam-wise, different philosophies of when to palpate, but at least for observations, look for deviations, asymmetries, etc. Just point out to your patient, your student, what they need to look at and get the clues of upper trap tightness or Gothic shoulders, etc. If you tend to do it, I tend to do it twice. So in palpation, I'll do it in sitting also, so you can go through those components of it. They can start going through with kind of a cervical exam. Is a link to an SFMA assessment, which I think is a good way to kind of teach them what normal is. The video is fairly good. It gives you everything. We want to look at the cervical upper extremity part, but look at the whole video. And look at, remember, cervical flexion, the criteria has to be pain-free. The patient should be able to touch their chin to their sternum, and no excessive effort or appreciable asymmetries or lack of motor control. If they can't do that, can't do any of those, then it's an abnormal test. Cervical extension, just remind your student looking for pain-free range of motion, taking a line from the chin to the forehead, and the patient extends their head backwards, and you look for that line to be 80 degrees or 10 degrees from the horizontal, and you don't want to look for it should be no excessive effort or asymmetries. Cervical rotation, it should be pain-free. You should be able to get their nose into midline of the clavicle to be normal. And again, no excessive effort. So if any of those are abnormal, it's an abnormal range of motion. Same thing you could do with side bending. You could have them bring their ear towards their shoulder, look for asymmetries, etc., and deviations. Next part we do what's called regionalization testing or localization testing. This will help them differentiate from an upper cervical, lower cervical, upper thoracic problem. The example might be if somebody can't turn their head to the right, they have limited range of motion, and then you have them go to C1, C2, so flex their head to C1, C2. If they have normal range, then C1, C2 is ruled out. Next thing you have them do is rotate their upper trunk all the way to the left, and then turn the head back to the right. Now you're taking out the upper thoracic. If they're pain-free, you know it's an upper thoracic problem. If the pain increases, we know it's more of a mid-cervical problem. Read through that part. And again, special tests, quadrant tests. When we go towards that position, look for radicular symptoms. We could do a Sperling's test. We could just do it with a side bending or side bending with rotation. And we can do add some compression, traction in 3 different positions, depends on what part where you're trying to work on. You're trying to decompress where in the nerve, in the canal where the foramen where it comes out. Then we do some clearing tests. So let's go over an Apley's. What's a normal Apley's test for ER? The patient should be able to touch their opposite spine of the scapula. It should be smooth. They should have about 170 degrees of flexion, abduction, and pain-free. Apley's internal rotation. Reach hand behind the back. It should be able to touch the opposite inferior angle of the scapula. It should be smooth motion. The scapular position might get slight winging, but it shouldn't be excessive. If it is, and elevation, elbow and wrist, hand go to end ranges with overpressure. As we move on, we go through myotomes, and the key here, like we did in the lumbar, is these are typical myotomes. You might have a little bit different of what you use every day, but either way, as long as we're being fairly consistent, do repeated testing, and the dermatomes are what we're using there. Reflexes, here's the typical C5, C6. The only one that might be a little bit different for you is C8, which is just tapping on the extensor mechanism, just distal to the elbow. Hoffman's looking for upper motor neuron. They can practice that. You can practice upper limb tension test. The biggest thing for me is that when you do upper limb tension test 1, the key component is you block the shoulder, patient's shoulder, to stabilize the scapula. You go through each component of it, make sure you're not pushing down, but you're just blocking it. And the key to any kind of neural testing is that make sure there's normal range in each joint before you start to test. upper motor neurons again for supine, Babinski. You can do that if needed. Let me go through palpation in this position in supine, SC joints for tenderness, AC joints. Then you can again get some of the suboccipitals, upper traps, etc. You can read through that. If you're not sure of the next test will be the neck flexor endurance test. You can look watch the video. More palpation prone. Again, if you do central PAs, unilateral PAs, is the time to do it. You can take up the slack and see if there's springing in all those joints. If you don't do unilateral or central PAs, you can also do mobility testing, side lying, and get them into a position and do side and do a translation through each segment to see mobility. Your choice. The special tests. These are clusters. So we have a Sperling's distraction upper limb tension test for cervical radiculopathy, headaches, usually a cervical flexion with rotation test. And you could do C1, C2 mobility testing. It would be hypomobile. For motor control is neck endurance testing. Okay, that's it for week number 5.